bonjour à tous. Donc, on a le plaisir d'accueillir Patrick Bossuit, qui est professeur d'épidémiologie clinique à Amsterdam et chef de la division de santé publique et méthodologie clinique. Je parle en français parce que lui aussi parle en français, bien qu'il préfère s'exprimer en anglais pour les aspects méthodologiques et techniques. Donc, c'est lui qui a mené l'ensemble du groupe START pour réaliser les recommandations des publications, sur les publications et les rapports des études d'exactitude diagnostique. Donc c'est vraiment un grand spécialiste des méthodes d'évaluation des tests médicaux. Voilà, donc sur son CV, on dit qu'il est auteur ou co-auteur de plus de 800 publications dans les journaux à lecture, un comité de lecture. Voilà, donc merci beaucoup d'être là avec nous. Merci à vous de venir assister à cette conférence.
Merci pour l'invitation et merci vous tous d'être venus ici sur un jour d'été pareil. C'est exceptionnel. Donc je parle français, je suis belge, mais je préfère le présenter en anglais. Donc, my topic of today is about spin in biomedical research. And I will explain what spin is during the presentation. And it's something that interested me because sometimes when you study elements, you know what to expect, but this surprised me. So part of this research was funded by the Methods in Research on Research project, MIROR, which is a collaboration between universities in Europe and led by a group in Paris. And the applicant is Isabelle Boutron. So maybe actually before you went out this morning, you looked in the mirror, and in the mirror you evaluated your appearance. Maybe you needed to adjust your clothing. You probably were not wearing a tie. Maybe your hair was a bit ruffled, so it's perfectly normal to look in the mirror and make these minor adjustments. Actually, everybody does that, even presidents. And maybe actually it was not just adjusting their tie, maybe there were slight deficiencies in your face that you needed to camouflage for the outside world. It's not just the females, we know that the males do that as well. Have a close look in the mirror. Actually, is this how we would like to present ourselves to the outside world? And maybe the males as well actually need to camouflage small spots which they don't like that much. Cover them up, hide them for the eyes of the people that we would like to meet. And some people even go one step further and they think about cosmetic surgery because they don't like their appearance and they say, I want to make a few changes in my face or other elements of my appearance. And you and I can have discussions about what is acceptable or not. Is it acceptable to use makeup? Is it acceptable to use, or is it also acceptable to use plastic surgery or cosmetic surgery? Because it's important, so there's only one time to make a first impression. So on your first date, so what will happen to this couple once they've seen one another outside appearance? So first impressions matter. They also matter in politics. There's only one time to make a first impression if you're meeting presidents and in thinking about job interviews. If you go for a job interview, only one time to make a first impression, and first impressions are very influential. So what is acceptable in, are you hiding the truth, or are you camouflaging the truth about yourself, or is it just natural to present yourself in the best possible way? So that's about personal elements, but how about research? If you present research, what's honest? So what is makeup in research reports, and what is plastic surgery in research reports? And what is acceptable and what is not acceptable when you report the findings of your clinical research? That's an interesting question. So are we do cosmetics for study reports exist? And are they allowable? And does plastic surgery for study reports exist? And is it allowed and justifiable? So that's the topic, more or less. So it's to what extent is presenting yourself in the best possible way in study reports done, and is it acceptable? So what I will present in this presentation is to tell a little bit more about these makeup elements in study reports, which I will refer to as SPIN. I'll also explain where the terms come from. I will explain what SPIN practices are. I will try to convince you that SPIN is problematic, not in your personal presentation, but we're presenting research. And I will present some remedies in about a half hour. So let's start with the SPIN in the study reports. SPIN actually was first defined by Richard Horton. He is still editor of Lancet, but he wrote this in the British Medical Journal. And it's an article about the rhetoric of research. He says, how a naturalist's life would be a happy one if you only had to observe and never to write. So just observing in research, wouldn't it be wonderful? Now, a few years later, SPIN was defined in this paper, and it's in a paper that discussed actually the honesty in reporting, and it was performed by actually one of the authors who later became a leading author of one of the major textbooks in clinical epidemiology. This is the couple Fletcher. Fletcher and Fletcher is well known in epidemiology because of this basic textbooks, which is used in many institutions. It's used in our institution as well. And it's quite interesting that an epidemiologist writes about SPIN. By the way, Fletcher, Robert Fletcher, was also for many years the Annals of Internal Medicine, one of the well-known clinical journals. And he wrote about SPIN in research reports about the Vioxx case. And the Vioxx case was quite an extreme case where a manufacturer deliberately tried to hide the side effects from a drug which later had to be withdrawn from the market. So that was the first mention of SPIN in the scientific literature in general. But in later years we had more systematic explorations about SPIN, about misrepresentation in clinical study reports. And this, for me, actually was the most influential one. It was published in JAMA by a French group, Isabelle Boutron, and with collaboration of English colleagues. And they looked at a very simple issue, randomized clinical trials, which were with non-significant results in the main outcome. So you say, this is a clear case. You do an RCT, you have a primary outcome measure, your hypothesis is that the new treatment is better than the old one, and then the trial data do not lead to rejection of the null hypothesis. So non-significant findings. Treatment does not work or does not help. But what did they observe? They observed that a fair number of these studies were able to present the results in such a way that the treatment that did not help or did not work was presented in a favorable way. Actually, for the majority of a large section of the articles in their analysis, presented the results in such a way that an innocent reader could conclude that the treatment did help and did work. I will skip this in the interest of time and go to the next paper. So randomized clinical trials with a negative outcome and are still presented in a very positive way. The second paper by the same group more or less actually looked at the classification and prevalence of SPIN in abstracts of non-randomized studies evaluating an intervention. And this is slightly more difficult because you have non-randomized studies, so the structure is not as clear as before. But nevertheless, they saw that a very high number of abstracts of reports show the misleading representation of the results in such a way that, again, an innocent reader could believe that the treatment actually was helpful or beneficial. Now, my own area is the evaluation, as Paul explained in the beginning, is the evaluation of medical tests. And in our group, we discussed, does the same principle exist in medical tests? So do we also see generous presentation of results and encouraging formulations, expressions of the benefit of medical tests? So we decided to look at diagnostic accuracy studies. So diagnostic accuracy studies, if you remember, these are tests that estimate, studies that estimate the sensitivity and the specificity of a test by comparing it to a reference standard or the gold standard. So very straightforward study design. So a PhD student and the rest of our team came up with a coding scheme to find out whether the study report was honest or not. And what we found was actually disturbing, because using a very strict definition of spin, so of generous presentation of the results, we found actually that about 1 in 3, or 3 out of 10 of studies published had an overinterpretation of their study results. Now, what does that mean exactly? So we included over 100 diagnostic accuracy studies over a variety of journals, so they were imaging, non-imaging, lab medicine, and elsewhere. And what we found out is that the abstract of the study presented the findings in such a way that they didn't match the study results. So people were enthusiastic about the medical tests, but if you looked at the study results, there was no justification for it. In about 1 in 5, we noticed that the conclusion in the abstract was much stronger than the conclusion in the main body of the text. And you know that people typically first read the abstract and then the main body of the text. So the abstract primes the reader into a positive way. By the way, this also happens frequently to titles. That titles are more positive than the abstract, and the abstract is more positive than the actual study results. We also noticed that authors could not resist presenting the results for subgroups sometimes, where the subgroups showed more favorable results than the main study group. And sometimes they made a conclusion which had nothing to do with the main purpose of the study, like saying that the test was found to be very useful where they only evaluated accuracy. And usefulness is not the same as sensitivity and specificity. It's a different issue. So about 1 in 3 of these articles had a form of overinterpretation. Now, I said before, I'm a skeptic. I'm used to all kinds of study results, but this result really surprised me, because this was so abundant and so prevalent that I felt stupefied. This is a very systematic pattern in study results. Now, why actually is there so much room for overinterpretation in diagnostic accuracy studies? Well, here you see a number of the facilitators for generous interpretation. Almost 90% of the studies actually did not have a hypothesis. Now, if you have no hypothesis, you can draw any conclusion, because you don't specify a hypothesis in the protocol, so anything goes. Most of the studies do not report the confidence intervals around the accuracy estimates. Now, if you estimate correctly identified 9 deceased in the total of 9, so 9 out of 9, you can say hooray, but then you should also include the imprecision. There were only 9 cases. If authors don't do that, they have maybe room for optimism. They very often did not specify subgroups, they did not specify thresholds, so there was ample room for a generous interpretation of the study results. Now, it doesn't end there, because then we said, well, maybe systematic reviews are better, because people that do systematic reviews will try to synthesize all the available evidence, and they will give a fair and honest representation about what's in the individual studies. So maybe we thought systematic reviews do a better job. They have a fair presentation of all their study results. Well, forget it. most systematic reviews conclude in a positive way about the study that they evaluate. So even authors of systematic reviews cannot resist the temptation to come with good news, that the test is accurate, that the test is helpful, and that the test is beneficial. And again, I won't take you through the actual study results. I will skip that in the interest of time. But the most authors just end in a positive way, even if they make a systematic review. There are exceptions. There are a few that say this test is not useful, not ready for prime time, but the majority makes a positive conclusion. So we see that spin, presenting results in a positive way, is quite prevalent in randomized trials, in non-randomized intervention, in diagnostic accuracy studies, and in systematic reviews. Now, why is that a problem? Why do I think it is a problem? Well, there should be a warning against spin, because spin eventually leads to waste. We know that there is avoidable waste, that people ask the wrong questions, do the study in the wrong way, do not report the study in full, and then present the study results in an unusable way. So these are the four main sources of avoidable waste in research. Now, why is spin problematic? Well, if you are too enthusiastic about the intervention, it will invite other people to do studies on the same intervention and the same tests, which may not be needed if you had given a fair presentation about the mediocre performance of the intervention or the mediocre performance of the test in the first place. So spin, as we see it, is a main source of avoidable research in waste, and it has been estimated that 85% of the total efforts in biomedical research are wasted, and part of that is due to spin. Now, how does spin work? So what are the practices that we identified over these various areas? Well, part of it actually is due to the fact that there's selective reporting. So if you look at the reporting of diagnostic accuracy studies, we know that within a year and a half, only 20% of the studies are reported, and that even 5 years after finishing the study, actually still a minority of the studies that were initiated are actually reported. So we know two things. There's selective publishing, and there's too optimistic presentations. And by combination, this generates too rosy field of the state of medicine. Too much positive news about interventions and medical tests. The practices are as follows. I can illustrate them by looking at biomarkers in ovarian cancer, which is our latest review. We've are doing a study on biomarkers in ovarian cancer to see how prevalent spin is in these studies. So this again is a systematic review we performed with 2 students in the MIROR project, and we looked at original evaluations of the clinical performance of biomarkers in ovarian cancer. We looked at recent studies published in 2015 and included 200 study reports. And I'm going to give a few examples about actual studies and these practices in spin in ovarian cancer. And these are both diagnostic markers, staging markers, prognosing markers, all areas of medicine, not just diagnostics. Here's the first example. This is a study that looks at a new approach for multi-omics data in ovarian cancer. And the authors present a whole panel of very intimidating series of methods, and then they look at the clinical outcomes. And the clinical outcomes actually are evaluated in different stages of ovarian cancer. And if you look at it critically, the performance, this multi-omics panel, does not perform as well in all kinds of, all stages of ovarian cancer. But guess what appears in the abstract? Only the positive finding in the subgroup where it performs well. Second example. This is a very radical one. This is a new score to identify ovarian cancer patients which are no candidates for surgery. So it looks like a valuable score in the title. It's a new score. It says a validated score because we now can identify the patients who actually need surgery. Now, I won't take you to the whole paper, but it's quite interesting to read. because the paper is based on a number of markers, and the markers in this evaluation were found not to be prognostic for the benefits of surgery at all. So in actual fact, if you read the results clearly, it's actually the performance is lousy. But in the exercise, the authors identified 2 new markers, and they suggest that these 2 new markers can help in the future to identify people who would benefit from surgery. So again, a radical misinterpretation of the study findings. So they looked at these so-called KLKs, which were found not to be useful in identifying the people who benefit from surgery, but other markers in this study were now put forward. Well, wait a minute, we have new markers, and these were better than the ones before. And they present an ROC curve, not of the actual score, but of the new markers. So a complete twist of the study purpose and the presentation of the finding. And if you read the title, it looks like there's a new validated score, where actually the study results present the opposite. Now this happens on and on. You have language like this one, like this marker may serve as a useful diagnostic tool, but if you look at the actual performance, the only thing that the authors did was to see if there's a difference in the means. Now, a difference in the means does not make it useful, does not even make it a diagnostic tool. It only shows that the subgroups that they were interested, cancer patients and healthy controls, had a different mean. So a complete mismatch between the study design, the conclusion, and the title of the paper. And this is extremely prevalent. In the interest of time, I will not give the other examples. So it's very, very, very common in the biomedical literature. And once you start looking for it, it's everywhere. So what are these spin practices? And maybe you can take away a few if in the future. Well, there are issues about presentation and there are issues with interpretation. The issues with presentation are the use of selective analysis, so only presenting the ones that support your hypothesis. Selective outcome, only reporting outcomes that support your hypothesis. Only selective subgroups that support the hypothesis, or thresholds that report the hypothesis. A mismatch between the abstract and the title, or between the title and the main paper. It's also in interpretation. You see strong titles that are not supported, strong abstract, mismatches with study design, mismatches with study results, and ignoring the limitations of the study. Now, what are the facilitators? I mentioned them earlier on. Well, if you don't specify the intended use, have no hypothesis, don't specify the subgroups, don't specify the thresholds, don't specify the statistical test that you're going to use, do not report imprecision, and ignore the limitations, you can go anywhere with your conclusions. So it's quite severe and quite worrying for ovarian cancer that there's such an abundance of positive findings. In fact, I believe that this is one of the main contributors to the failure of the biomarker pipeline. Earlier this summer, I was able to publish this with John Ioannidis about the waste, leaks, and failures in the biomarker pipeline. So the ubiquitous significant results are a real problem. If you look at the biomarker pipeline, it looks like a very neat pipeline from discovery through validation over translation to implementation. Well, I believe the pipeline looks more like this, actually. An abundance of positive findings and leaks everywhere. In the end, there's not a single drop that ends in clinical practice. We should do something about it. So what can we do? And I believe this is urgent. What can we do? What can you do to remedy spin? Well, here are a few solutions. I think before the study, we should think about the study question and the study hypothesis and have a protocol. So all studies should have a protocol. It's very logical, but in test evaluation, I know many studies don't have a protocol. So specify where you want to go to, specify your conclusions. And there are different types of guidelines for strengthening the protocol. For example, the Stratos initiative by biostatisticians is a specification of desired methods to pre-specify in the protocol to evaluate study hypothesis. You should also register studies before you start them. So announce to the outside world how you're going to do the study. It now exists for clinical trials, but you can register any study, any trial in clinicaltrials.gov, not just randomized trials of medication. So register your study. The second element is looking for balance. I think any study, any trial should have a balanced theme. It should have optimists and pessimists. It should have skeptics and people that like to see things in a rosy brill. So here's one of the skeptics you may want to include in your team. But we also have to do something about the training of researchers. I think integrity is not just about avoiding fraud, but by learning students like you about using the right methods. So the main problem in science is not fraud, but is sloppy research. So we should train people about the right methods. So balance the research team, have professional skepticism, have a protocol, review the protocol, publish it, and train the investigators. Now, how can you avoid spin once a study is done, once a study is actually performed? And people will say, well, hooray, we finished it, now we have to get it published, so we have to make a very rosy presentation of the results, otherwise nobody would be interested. I don't believe that. I believe in fairness. So there again, we should have a fair presentation of the study results about the pros and cons. We should use reporting guidelines to verify that we have a balanced presentation, such as START for diagnostic accuracy studies and CONSORT for randomized trials. So we need reporting guidelines. START was recently updated. That's a small commercial break for diagnostic accuracy, and we rely on peer review. So peer review should not just recommend to the editor whether a study has to be published, it should also identify spin and attenuate spin. So editors should say, oh, wait a minute, this is way too optimistic a conclusion. We should balance that. I think peer reviewers should be and could be trained to identify spin and to limit it. It is quite difficult because studies have shown that the editors are also inclined to add spin to study results, to make the study more attractive, to look more attractive in the paper. That should be corrected as well. So peer reviewers should be encouraged to identify spin and to limit spin, and we know that that can be done. Just last week, or 2 weeks ago, there was the International Congress on Peer Review and Scientific Publication in Chicago, and spin and the obligations of editors was one of the topics that was discussed there. I think we should try to do something about it. One more thing. So if we have optimistic titles and if we have optimistic abstracts, my proposal is to invite the reviewers to write the title and let the reviewers write the abstract. Because the reviewer has no interest in making the results too positive or too rosy, or the abstract too generous. This is not something that the author should do. The reviewer should write the title and the reviewer should write the abstract. And maybe also the reviewer should highlight the limitations of the study. Why do authors have to announce their own limitations or forget to highlight the limitations? Maybe the reviewers should add to that. So in the end, we need spin doctors. I think we do not only need researchers and strong researchers, we also need people that identify too generous and too optimistic and too rosy presentations of study results. So we need balanced teams, reporting guidelines, and we need reviewers and editors or spin doctors to write critical elements in the study reports. And maybe they can use a spin detector, some instrument, natural language processing, to identify rosy language and generous interpretations and optimistic conclusions. So in the end, I think it's reasonable for people to look into the mirror before we go out and to adjust your tie if needed. But I don't think that using cosmetics or plastic surgery is justified in study reports. We should do something about spin. We should try to detect it, try to identify the limitations, and try to identify too generous and too optimistic conclusions about study results. And with that plea, I would like to end this presentation, thanking you for your attendance this afternoon. Thank you very much.